Thank you for joining. This is our Know Your Rights webinar. This is a collaboration between Kentucky Voices for Health and our friends Kentucky Equal Justice Center to cover some stuff about No Surprises Act, appeals, and medical debt, and just some consumer information about the rights that you have, and not letting yourself get bullied by the insurance companies, because they will. Given the opportunity, insurance companies will do absolutely everything they can to make a buck, and that's not disparaging. That is just the facts. That's how they're set up. So we want to make sure that consumers understand the rights that they have. And so we're going to dive into all of this. We will be happy to share the slides after this. And just a housekeeping note, this again is very dense material. So if you have questions, please feel free to pop them in the chat as we go along, or come off mute and just say, hey, actually, I don't understand what you're saying. And we can walk through it there. So if you have questions afterwards, we'll send out the slides. If you have questions afterwards, definitely feel free to reach out to us, and we can help answer any questions you have. But otherwise, let's just get going. So here's our agenda for today. Again, covering No Surprises Act, appealing insurance denials, hospital financial assistance, medical debt, all the juicy stuff that people really want to know on a Thursday afternoon. So let's get started with my section, and then I will turn it over to Chloe. So hi, everyone. I'm Priscilla Easterling. I should have started with that. I'm our Director of Outreach and Enrollment for Kentucky Voices for Health, and I'm also a connector. So I help folks do that outreach and enrollment as well. So when we talk about the No Surprises Act, first of all, what is the No Surprises Act? That's super complicated, but in a lot of ways, people have understand what it's trying to do. So before the No Surprises Act, which was passed in January 2022, if you had health insurance and if you received care from out-of-network provider or even an out-of-network facility, even just unknowingly, your plan did not have to cover the whole cost, and they may not have. So a really good example of this, folks, that we use is you have an emergency situation. Yeah, you you start having pain in your right left side. You think it might be appendicitis, so you check your provider. You check your provider directory, you know your insurance plan, you know that the hospital down the street is in network. So you go to the hospital, and while you're there, they do blood work. They do a CAT scan. They do determine that, in fact, it is an appendicitis and you need to have your appendix taken out. And so then when you have your appendix taken out, you have anesthesia, hopefully, because that would be wildly painful without it. You have all of the other folks who are in the room that you may not know about. Well, before the No Surprises Act, you could have been balance billed for any of the people who were in that room who were out of network, even if you were at an in-network facility. So that anesthesiologist would send you a separate bill, the lab tech might send you a separate bill, the facility where they ran your lab work, they might send you a separate bill. There are lots of ancillary charges, is what they've called it, where you might get a surprise bill, even if you did everything that you knew to do, which is make sure you go to an in-network hospital, in-network facility, to see your in-network provider. But there were lots of ways that consumers were getting caught up with out-of-network bills, just even unknowingly. And so those unexpected balance bills from out-of-network providers are what we call surprise medical bills. And before the No Surprises Act, the average cost for consumers, that $1,200 for anesthesia. So in this example where we're talking about an emergency appendectomy, you go to an in-network provider, that you could still get a surprise bill after your insurance covered everything, a surprise bill for around $1,200 for anesthesia, $2,600 for surgical assistant fees, and that does not include lab work or any of that. So those surprise medical bills are just absolutely scary, sticking with our Halloween theme. And luckily, folks who already had Medicare and Medicaid, they already had protections from these surprise bills. But folks who were enrolled in any other coverage, they did not have these protections. And so just further digging down, just definitions, balance billing, because we're going to use that term a lot. When provider bills a consumer for balance remaining on the bill that a consumer's plan doesn't cover. So again, you go to the hospital, the part of having insurance, first of all, is that the insurance company has negotiated with that in-network provider to have an allowed rate. And once you seek that service at that in-network provider. If there was something else, if there was another provider in the room who was out of network, they could balance bill you for the difference between what the insurance company covered and what you actually paid. And that's what they call a balance bill. And so a type of surprise billing. Now, what the No Surprises Act has done, again, it protects people who are covered under several different group health plans, group and individual health insurance coverage, federal employee health plans, and it really works. It really works to it really specifically applies to most emergency services. Wow. Um, and that's everything that's, um, if you have an emergency come up, they use a very specific uh, definition of emergency as in what a layman's person would assume is actually an emergency. So you're feeling pain, you go to the hospital, you thought it was appendicitis and it turned out to be gas. Your insurer is still required to cover that at that in-network emergency service rate. For the NSA, which I like to say because it also makes me feel cool and fancy, like maybe I'm a secret spy when really I'm talking about health insurance. But NSA provides not coverage and protections for non-emergency items and services from out-of-network providers with respect to in-network facilities. So that, again, that exact example of going to your in-network hospital, but the anesthesiologist in the room is not in-network. The No Surprises Act protects you from additional billing, from additional surprise billing from the anesthesiologist who is out of network at your in-network facility. And it also has some specific protections for out-of-network and air ambulance service providers. Now, on the other side, NSA does not do everything that it can. It does not apply when there are non-emergency items or services that you go to an out-of-network facility. So you are traveling and you just want to go to the doctor because it's fun. It's not an emergency. You want to check up, something's going on, but it's not an emergency. Um, the there are no surprise billing protections there. If there are circumstances when a provider is able to, you go to the hospital, they let you know, hey, we're actually not in network. It's not an emergency. We can help you, but if we do, we're letting you know, hey, we're out of network and this is what you're going to have to pay. The No Surprises Act requires that providers and facilities, hospitals have to let consumers know when they're out of network if it's in a non-emergency situation and give consumers the right to make the decision. Do I want to pay this out-of-network rate, or considering it's not an emergency, do I want to go to my in-network facility? Do I want to wait till I can go see my in-network provider? All of that. And then when items or services provided are just not covered by your health insurance plan, so if it's just not a covered benefit, it does not matter. You can still be billed that full amount for it. And it also does not cover ground ambulance services. So that's a place where there's still some advocacy that's needed there to include ground ambulances. So getting a little bit more into it. So it provides surprise bills for, actually, um, surprise bills for most emergency services, and that's going to include post-stabilization services, and that includes any out-of-network hospital or independent freestanding emergency departments. That can also include behavioral health and SUD facilities. So if it is an emergency and you need to seek treatment, this protects you from those surprise bills. If it's not an emergency, and it's non-emergency services from an out-of-network provider delivered as part of a patient's visit, to participating healthcare facilities that are in network. Again, it prohibits those bills. Um, and then also air ambulance services. Let's move forward. Under the No Surprises Act, some of those emergency services, so again, they must cover emergency services as defined as an emergency service at that same in-network rate, regardless of if it's out of network or not. Health plans and health insurers are prohibited from requiring prior authorization during emergency care, and they have to determine whether or not a condition is considered an emergency medical condition based on the presenting symptoms and not a final diagnosis. So again, if you go to the hospital, you're in extreme pain, your side really hurts, you really think it's appendicitis, you just need that assistance. Your insurer still has to treat it based on the presenting pain, presenting symptoms, and not on what the final diagnosis code is. So if you go to the hospital, you do all the tests, and it turns out, oh, it was gas. I don't know why I chose this example, but it turns out that it's just gas. They can't say, well, in the end, it turned out to not be an emergency, so we're not going to cover it at that emergency as an emergency service. They have to treat it based on those presenting symptoms. And out-of-network providers of emergency services cannot bill more than the in-network rate based on the consumer's plan or insurance. And they can't balance bill for post-stabilization care. So once the emergency has passed, they are working on stabilizing you. They're giving you the IV fluids. You're saying for monitoring, they can't balance bill for those services. And again, they use the definition of emergency services is using a prudent layperson standard. So just if you talk to the average person on the street and presented them with symptoms, they have some general knowledge of like health and how humans and bodies work, and you tell them, hey, I went to the doctor for this, I went to the emergency room for this, would the average prudent layperson actually agree that that was an emergency situation? Probably. If yes, then that's considered an emergency services. If no, then it's probably not. So there's a little bit more leeway there so that it's not just what a medical professional might deem as an emergency, or what your insurance company might deem as an emergency, but just the average consumer, what would they assume? So here are some examples of some of these emergency services, specifically the things that are going to be covered and where. So types of services, that's going to be ancillary services to evaluate whether an emergency medical condition exists, any examination and treatment needed to stabilize the patient, and then post-stabilization services. So part of that outpatient observation, inpatient or outpatient stay, for whatever it takes to make sure that the patient is stabilized before release. This does include all hospital emergency rooms, departments, any hospital departments caring for ER patients once they're stabilized, independent freestanding emergency departments, and any urgent care centers that also meet that definition of independent freestanding emergency departments. And this also applies to physicians, physician assistants, nurse practitioners, and any other medical providers acting within the scope of practice and through law. So that's very broad to make sure that they're covering all of all of the bases of who consumers might run into, who you might run into when you're going to the emergency room seeking treatment, and who might be trying to balance bill you. So all of those folks are subject to the No Surprises Act with respect to emergency services. Now, there are also, as I talked about, there's prohibitions for non-emergency services. So when these services are provided by out-of-network providers, but you're at an in-network facility, your insurance still has to cover that service at that in-network rate. So regardless of the fact that the person might have been out of network, it still has to be covered at an in-network rate if you're at your in-network facility. So again, one of the things that we hear so frequently is about, folks going to the hospital and you just have no control over the people who are coming into your room and providing care and doing services. Even if the hospital's in network, so many times the folks who are coming in and out of your room are not. And so this is to give some additional protections for those folks as well. And in that setting. So here's, again, some examples of all of the healthcare facilities included: hospitals, ambulatory surgical centers, critical access hospitals, that's a big one. And then some of those services that are included: pre-op, post-op equipment and devices, telemedicine services, and then ancillary services, which I have a graphic of next. And this one has a much more extensive list of everyone that's included. And again, anesthesiologists, I don't mean to call them out. They're great. They do an important job, but that is one of those big bills that we hear folks getting pretty often. So when I talk about ancillary services, this is what I'm talking about. Emergency medicine, anesthesiology, neonatology, pathology, radiology, diagnostic stuff. All of these are included in the No Surprises Act. So you cannot be charged that out-of-network rate for any of these services in an emergency or a non-emergency situation and in-network facility. That's a mouthful. That's a lot to try and absorb, but it's great. It's additional protections. So, and then for the last one, the air ambulance service, there are surprise bills. We hear a lot with ground ambulances, which is why, again, there does need to be some more advocacy around that. But for air ambulances, they are generally going to be covered as an emergency. Most people are not able to just call up an air ambulance for any old reason to get airlifted somewhere. That's not a thing that really happens. But just in case, the No Surprises Act just generally prohibits any surprise billing for air ambulance services, regardless if they're out of network or not. Most air ambulance services are almost always out of network. And so it's almost always an emergency. They all have to be covered at an in-network rate. And here's a little chart breaking that down a little bit more. And just that definition, it could be a medical helicopter, it could be a medical airplane. Either way, air ambulance have to be covered at an in-network rate. So, now, when do these protections apply? This covers a lot of different plans. I already mentioned that Medicaid and Medicare had already enjoyed these protections for years. Now, employment-based group health insurance, both self-funded and fully insured. So any coverage that you get, most coverage that you get through your employer, NSA is going to apply to them. Individual and group marketplace, so anything on Connect, that's also going to apply. Any non-federal governmental plans that are sponsored by state or local government. A really good example is coverage through a school district. Those are also subject to NSA protections. Certain church plans are also in there, but that does not include healthcare sharing ministries. Healthcare sharing ministries are by definition not technically health insurance, and so they're not subject to these plans. But other church policies do fall under this. health benefits offered through the federal employees health benefit, and then also student health insurance plans offered by colleges or universities are also subject to the NSA, which is really great because student health, I have a whole spiel about student health insurance plans that I will not get into right now, but it's wonderful that they're kind of covered under this as well.
Priscilla, I don't want to derail you, but
Yeah.
Sonia posted a question in the chat asking what prevents a hospital from handing a stack of forms to a patient or caregiver and saying you need to sign these forms without explaining what the person is signing. Urgencies in particular often have distracted patients and caregivers. I think the answer to this is nothing, but I just
Correct.
I'm right.
You are correct. And that has been the actual problem with implementation that we've heard most. That when you're actually seeking treatment, very often you're given a stack of documents and just told to sign. Some of them will have a blurb. All of them are, all of the forms are required to have specific language letting folks know about the No Surprises Act, the patient's rights, and how to all of this information that we're covering today, and how to appeal all of that and what your rights and all of that are. One, we've heard a lot that they're often like digital. And so you're signing on a little pad. So you're not ever able to just read through it. And then two, that they're not handing folks an actual copy of what that information is, or doing any education in the moment about the No Surprises Act, or even just specifically calling it out. And then three, that the language that they're using on the form explaining the No Surprises Act does not make sense. People do not know what it means. They do not know what these protections are. It's too complex. Yeah. So yes, there is nothing that is stopping them other than they're not supposed to, and we should be able to report them when that happens. But it also takes a lot of consumer education to even know that they were supposed to get it, that they were supposed to specifically look for that document. And most consumers don't, most folks don't know. So you just sign whatever your doctor gives you, and that's it. And so we're starting at level one with just like, here's the education around it. And then we're also, if you have examples, if you have issues, if you see things like that happening, we can still report it. But yeah, there is nothing stopping hospitals from doing that. And unfortunately, they are. When switching back into this, when don't NSA protections apply? So for the folks who have Medicare, Medicaid, Indian Health Services, Veteran Affairs Health Service, healthcare, or any of the insurance programs that make up TRICARE, they already have those protections built into the program, so they don't have to worry about it. For other programs, short-term limited duration insurance, which we lovingly call junk plans, because they don't actually cover anything, and they are not great. Retiree-only plans, disease-specific plans, hospital indemnity policies, accident-only policies, and then standalone dental and vision policies. They also do not have these protections. But if consumers have a major medical health plan that does include dental and vision, then those protections could apply to dental or vision services covered by their health insurance, but only if they're embedded. If they're not, the medical does, but not the vision and dental. So I'm not going to get into this too much, but because again, this is a thing that we could spend a full hour just talking about calculating the payments. But when you're looking for information, I linked to some resources about this, about how the payments are determined and all of that. When we're looking at this, Kentucky does not have any additional state laws around No Surprises Act. They do not have any, we do not have the all-payer model agreement. And so the way that the payment structure is determined for insurance companies for consumers, it's going to be this third option, the amount that the lesser of. So the amount billed by the provider or facility, and then the qualifying payment amount for the item or service is generally going to be based on the median contracted rate that a health plan pays to providers in that same geographical region. So if they're going to look at the whole area and say, for this service, we typically pay $100, the provider billed $150, so the consumer is only going to be charged that $100 because it's the lesser of those two numbers. Again, I don't want to spend too much time because it's also very complicated. But they're always going to be looking at that lower rate for the consumer that they're to base the actual cost that the consumer is going to pay. So under the No Surprises Act, a consumer's cost sharing requirement cannot be greater than their health plan's in-network cost sharing requirement. So for example, if the service is subject to coinsurance and the health plan requires like 20% coinsurance by an in-network provider, and then for an out-of-network provider, it's 30%. I almost always see closer to 50%. Then the item or service is going to be subject to that 20% to the in-network rate. That's the whole point. In-network rate for for any emergency and non-emergency services at an in-network facility. And that's really complicated and goes back and forth. But just very basically, any emergency situation and then any non-emergency situation at an in-network facility, regardless of if the provider is actually out of network. The consumer is always going to be responsible for the in-network rate, regardless of that situation. Already feel okay. So for folks who do not have health insurance, or if they want to self-pay for a medical service, there are still additional protections under the No Surprises Act, and that version is the good faith estimate. So if you don't have health insurance, if you want to pay for your care out of your pocket, if you're choosing not to use it, you can ask your provider for a good faith estimate, and they will give you an estimate within 3 business days. They have to give it to you within no more than 3 business days to let you know what the actual cost breakdown of whatever service you're trying to schedule is. So they will tell you everything that's included, a list of the expected charges, who they expect the provider to be, what charges are associated with that. And currently, good faith estimates only list expected charges for a single provider, but you can request it for all of the providers who will be involved in your care, and they have to furnish that. And if they don't, that's also we can report that to DOI or CMS. So specifically, the estimate has to include an itemized list with specific details and expected charges, and they have to be given to you in the either printed or paper, or printed on paper or emailed. Here's an example of a good faith estimate, just what that might look like. If you have any examples, I would love to see them. Please feel free to email them. You can redact your name, but it's just helpful information, and it breaks down again, the information about what they expect the charges to be. And after you get your good faith estimate, you should keep it. And when you get your actual medical bill afterwards, if there is a difference of $400 or more from the good faith estimate, you can go through the patient-provider dispute resolution process. If you are eligible for a facility sliding fee discount, price, you can receive a complete good faith estimate with the undiscounted price. Again, just keep it for reference sake. And if they don't anticipate billing you for that, they're able to give you what they call an abbreviated good faith estimate that doesn't actually list any of the items or services, but it has to state the provider's commitment not to bill the consumer for any of those charges. Again, some timeframes around that good faith estimate. It has to be provided no later than 1 business day after scheduling. If the service is scheduled 3 to 9 business days in advance, it has to be provided no later than 3 business days ahead of schedule if the service is scheduled at least 10 days in advance. And it has to be provided no later than 3 business days after the date of request period. And it is good faith estimates are not required if the service is scheduled fewer than 3 business days or if it's an emergency. Yeah. Okay. So there's also part of the No Surprises Act. Part of this is on the insurers keeping their provider directory up to date. Those are half the problems, as that provider directory is constantly out of date. The contracts are changing and all of that. And the No Surprises Act provides some additional protections for consumers. For insurers to make sure that they actually take the steps to keep their provider directory up to date. And right now, there are no regulations around it. So there's like, here's the guidance, please do it. We want you to do it. There will be regulations coming. So you want to go ahead and do it now until we have to force you to do it. So it's kind of hit or miss, but they expect regulations hopefully next year. And if the provider directory is incorrect, if a consumer pays that bill, pays a full bill because they received out-of-network care due to inaccurate provider information, the insurer did not keep their provider directory up to date, the consumer can get a full refund from a provider of any money paid over the in-network cost. If it's on the insurer for not having up-to-date information, or if they billed for an excess and the consumer actually paid it. Okay, there are also continuity of care protections. Sorry, there's so much content here. I'm trying to roll through a little quickly. So if your in-network provider changes and you're in the middle of undergoing treatment for a serious complex condition or undergoing a course of institutional or inpatient care, scheduled for a non-elective surgery, pregnant and receiving treatment for pregnancy, receiving treatment for a terminal illness, and if you are receiving one of those, you fall under one of those categories, the No Surprises Act allows consumers to have up to 90 days of continued healthcare benefits with that provider under the same in-network rate. And that's to give them some time to find another provider, find someone else, and not just suddenly be cut off from treatment or suddenly be cut off from care. There's also an appeals process. There's an internal appeal process. So we would go through the Kentucky DOI process for any claim denials, for any out-of-network balance billing issues, surprise billing issues. We go through the Kentucky DOI. Their contact information is down at the bottom. If you have a claim denied or something along those lines, the first thing to do is to complete the internal appeals process with your insurer, file an appeal with your insurer. They are required to respond within 30 days of receiving your appeal, or if you file for an expedited appeal, they have to respond within 3 days. And if they do not, again, you can report that to DOI. And then there's also the external federal review process. So if we go through the Kentucky DOI process and it's just not helpful, you still believe that something wrong has happened, you can always go through the federal external review process, and they will work with the insurer and the state DOI to review the case and situation. So for more resources, there's a great CMS No Surprises Act website. They have so much content. This is so dense. There's so much more that we could be talking about but in the interest of time, I'm gonna move on. There's also a No Surprises help desk. So if you have more questions, if things come up, there is a great help desk and they're able to answer these questions. So with that, moving on to Chloe.
Thanks, Priscilla. And this is probably exactly right because you did the much denser thing today. So hi, I think I know most of you. For those of you who I don't know, I am Chloe Atwater. I'm the health justice attorney at Kentucky Equal Justice Center. We are a nonprofit law firm and advocacy organization. And I'm going to talk to you all a bit about medical debt from the perspectives of hospital financial assistance, credit reporting, and hygiene, medical debt hygiene. So disclaimer, I always have to add this. While I am a lawyer, I'm not your lawyer. If you need assistance specific to your circumstances, please contact an attorney. Low-income folks may be eligible through their local legal aid office. We're going to circulate this recording and the slides afterwards. So you should be able to click on it at that point, but otherwise we have included directions on how to get to find your local legal aid via the KY Courts website. Hospital financial assistance. So most hospitals are not-for-profit, believe it or not, which means that in exchange for not being required to pay taxes, hospitals are required to hold up their end of the bargain. And since the Affordable Care Act went into effect, one of the ways that they are required to do that is through having a financial assistance policy, which is sometimes called charity care. These policies don't have to cover anything more than medically necessary care and emergency care. And hospitals can decide to limit their policies, who their policies apply to. For example, it's common for hospitals not to cover people who are visiting from outside the state or especially outside the country, which leads to sticky questions about what it means for somebody to be visiting versus living in Kentucky. Hospitals also often have separate policies or do not cover organ transplants and similar procedures under their financial assistance policies, even if that's considered medically necessary. And here's my least favorite part as a lawyer. These regulations can only be enforced by the IRS, which, as you know, enforces the tax code. But if a hospital takes what are sometimes called extraordinary enforcement actions, such as referring a bill to a collection agency or suing a patient without first assessing them under their existing financial assistance policy, an attorney might be able to use these requirements under the Internal Revenue Code as a defense in a medical debt collection lawsuit. Next slide. So while people can't use these regulations to sue, financial assistance policies can be very generous, even including people who have health insurance. So over the past several years, there's been a huge increase in patients' out-of-pocket expenses with private health insurance. That's been, for the past 2 decades, but that rate is increasing. For example, a revenue cycle management company, which helps hospitals and providers, wring the money out of people. That's their job. Found that when they were looking at bad debt, so the debt that the hospital can't get payment for from anyone, in 2018, only about 11% of bad debt was what was left over for an insured patient to pay after insurance. But in 2021, that was almost 56%. So there are probably several reasons for this. One of those is that more people had coverage at the time because of pandemic era policies, but based on the other statistics that were in that report that showed just how many, the size of the outstanding bad debts that people with insurance had, it does seem like this is, it does seem like one of the big drivers here is that people are increasingly choosing or being, the most logical option for them for health insurance is a high deductible health plan. And for people who do have those really high deductible plans, hospital financial assistance can really help. For example, UK healthcare policy covers folks with up to 300% of the federal poverty level, and they actually, if you're anywhere within that range, they cover that care at 100%, except for a small copay. It's not a copay because it's not insurance. So, but I think that they chose that nomenclature because people will be familiar with it. But you can see, based on this chart, like 300% FPL that encompasses a lot of people, a lot of families. And every hospital is different, but this may be an option for a lot of people. I think next slide. So to learn more about your particular hospital's financial assistance policy, or to find out if you qualify, you can search financial assistance on your hospital's website. I would tell you to navigate, but that doesn't always work. They're supposed to publicize these policies. There are some really robust protections in the Internal Revenue Code. They explain, that hospitals are supposed to publicize these policies, and they're supposed to post them in the hospital. And it seems like if every hospital were following these regulations to the T, we just wouldn't be in the situation that we are. And it's the fact that it's not enforceable privately that leads to all of these problems with it. So if we had an enforceable right of action, this would be a lot more helpful, but it feels like one of those things that it should be illegal to know, as it is right now. So $4 is a nonprofit organization that pulls in financial assistance policy information from every not-for-profit hospital in the country. Their form is available in English and Spanish, but does rely on partner organizations to use their own language access plans for completing forms in one of those languages for folks who require a language other than those two, if that makes sense. And I plugged in some fake numbers here just to see what it would look like, and it pretty promptly gave me the full form to fill out, and they do all of the interaction with the hospital so that folks can get on with their lives. It's a lot easier than individually tracking down policies for every hospital. So I would encourage you to check it out. And if you or someone that in the future is applying for financial assistance or might be a good candidate for it, I would encourage you to use it. Next slide. Perfect. So credit reporting. There's been a lot of conversation about medical debt on credit reports the past several years. That's because we know that medical debt is not a very strong predictor of creditworthiness. Medical debt is unlike a lot of other debt in that it's generally out of our control, in a way that consumer spending is not. While there are absolutely cases where people must have a car to get to work and the car with the lowest monthly payment is just still too high and they get behind on payments. But that's fundamentally different than somebody who has a heart attack, ambulance takes them to an out-of-network hospital, and they end up with a huge sum of medical debt. And they should be relying on the No Surprises Act to help out with that one too. But that the difference between most consumer debt and medical debt has been borne out in enough data that it led to this push to remove medical debt from credit reports. This slide just provides a general timeline of developments in this space, but the most critical thing to know is that right now, if a patient has a bill for, let's say, $400, and that bill shows up on a credit report after a 12-month wait period, that bill is too low to be reported, and the patient should contact an attorney. If a $600 bill shows up on a credit report in less than 12 months, they should contact an attorney. If a bill that a patient has paid off is showing up on a credit report, they should contact an attorney. But if a bill that started over $500 but is now under that because someone is paying, on a payment plan, and is showing up on a credit report, and it only started showing up after that 12-month period, for example, that's still permissible unless and until the CFPB rule is finalized, which is likely contingent upon the outcome of the presidential election. So next slide. So medical debt hygiene. I pulled a little graphic of a ghost taking a bath. I thought that it was festive for the day. What does medical hygiene, what does medical debt hygiene mean? To me, it's how you prevent and manage medical debt. As in medicine, with medical debt, an ounce of prevention is worth a pound of cure. To prevent medical debt, people should maintain insurance coverage to the extent possible and choose a plan that fits their needs and risk tolerance. It's open enrollment for marketplace coverage and Medicare, or actually, I guess, it's not quite open enrollment. Open enrollment starts in tomorrow. I guess it's tomorrow. But even with employer-sponsored coverage, we all need to make sure that we're considering the trade-offs between having higher premiums versus higher deductibles and out-of-pocket maximums. Apply for hospital financial assistance. I'm going to keep banging that gong. So many more people are eligible than who utilize it. Pay non-medical bills first. This is really unintuitive and really hard to wrap your head around as an average person who's just trying to pay for the care received. But one of the most harmful things that patients do regarding medical debt is prioritize it over other types of debt and other expenses. People should pay the bills that keep them in their homes and able to work first, plus food and other critical living expenses. So unless someone is granted a hospital or a debt collector a lien on property interest, in which case they definitely need a lawyer. That's, that is almost never the right call. It won't be medical bills that will get you kicked out of your home. It'll be not paying your mortgage or not paying your rent. Not having heat in the winter. Do what you need to keep yourself safe and healthy, and alive, and in your home. Make sure that medical debt stays medical debt. Related to the previous point, all of the credit reporting protections that we talked about on the last slide only apply to medical debts that are in the possession of the hospital or someone that they sell the debts to. So when people put medical bills on credit cards, that turns that debt into consumer debt. And why is that a problem? Credit cards bear interest. And even if it's the type of medical debt that would not normally show up on a credit report based on the newer protections or the future protections from the CFPB, of course, if it's a credit card debt, it will show up on the report and impact your credit score. And hospitals are much less likely to grant financial assistance if you've already paid the bill. It'd be a lot harder sell for you to go back and say, hey, actually, can you give me my money back, please? I want to apply for this financial assistance. And oftentimes there are time limits and things that hospitals impose on those applications as well. They don't have to observe them. They could choose to accept those applications later, but they don't have to. So to make matters worse, a relatively new trend is medical credit cards. Previously, medical credit cards were mostly an issue in dentistry and veterinary care and plastics. But corresponding with the rise in high deductible health plans, more and more healthcare providers and hospitals are promoting medical credit cards. Often these cards will lure patients in with 0% APR for the first year. but that typically balloons afterwards. And like other credit cards, they complicate getting financial assistance. So what should people do instead? Um, First and foremost, establish that financial assistance is not an option. If it isn't, ask for an itemized bill. We've all seen bills with wildly high charges that strain credulity. Um, and in that case, there is a huge, if there is a huge bill that doesn't seem legitimate, there may be a defense in a collections lawsuit because, like I said in the chat earlier, there are concerns with traditional contract law principles and hospital charges. Anytime that someone is handing you a piece of paper and saying, here, sign this, and there's no negotiation. There was a court case in Colorado a couple years ago that went to the Colorado Supreme Court, where the hospital had charged someone just an astronomical sum of money that didn't have any relationship to what other hospitals were charging for that amount of money. The patient had a reference-based pricing health plan, which is kind of its own thing, and it gets really complicated. But ultimately, this procedure, she thought that it was going to be covered. They told her that it would be covered. It ended up not being covered by her insurance. And as a result, she was just saddled with this huge bill that was, more than twice as much as it would have been at another hospital. And the court found that when you leave an open price term in a contract, which is what that is, when somebody hands you a form and says, here, sign this, that says, I will pay any charges associated with this care, that assumes, that open price term assumes that is going to be a reasonable price. So it was up to the jury to assess what a reasonable price would be for that procedure. So that's a really new area of law. It's something that I would love to see. I would love to litigate. If anyone ever comes across this fact pattern, I'd love to hear about it. And I'm sure that there are some other very eager attorneys in the state. But in most cases, though, it's still good to look at the bill just to make sure that you're not being charged for something that you did not receive, or charges aren't duplicated. And I know that we're close to time. I think I'm close to the end here. Once someone has established that financial assistance is not an option, the bill is legitimate. If the hospital still owns the debt, they will generally be flexible with setting up payment plans. Safety net hospitals will often take very low monthly rates, very, very low payments. If the hospital no longer owns the debt, negotiation may be an option. Collection agencies typically purchase medical debts for a very small fraction of the original amount, sometimes a penny on the dollar or less. The first step is making sure that the collection agency actually owns the debt, which they'll generally be happy to tell you if you ask. I can't get into all the nuances of, the protections that are available for you if a medical debt is held by a third-party debt collector versus if the original hospital still owns that debt, partially because of time and partially because it's just too nuanced, and it gets into the realm of legal advice. So I would recommend that if you end up in that situation and do need personalized assistance, please do seek out an attorney. And it could be me someday, but it's not today. So are there any, I didn't see any other questions in the chat, but I'm happy to take any in the remaining 2 minutes, as well as Priscilla.